Thank you for joining this OncLive Peer Exchange, a global perspective on sequencing treatments in gastroesophageal cancers. Chemotherapy still plays a significant role in the treatment of advanced gastroesophageal cancers. However, recent progress has extended survival and is shifting the landscape towards less toxic regimens. This OncLive Peer Exchange panel of international experts in gastroesophageal cancers will focus on the current understanding of molecular subtypes and how the availability of newer treatment options is prompting discussions on sequencing. I am Dr. Johanna Bendell, Chief Development Officer and Director of the Drug Development Unit Nashville at Sarah Cannon Research Institute in Nashville, Tennessee. Participating today on our distinguished panel are Dr. Peter Enzinger, Associate Professor of Medicine and Director of the Center for Esophageal and Gastric Cancer at the Dana-Farber Cancer Institute of Harvard Medical School in Boston, Massachusetts. Welcome, Peter. You have a really long title. Dr. Yelena Janjigian, now Chief of the Gastrointestinal Oncology Service at Memorial Sloan Kettering Cancer Center in New York, New York. Thank you so much from your new busy role to join us today. Thank you. Dr. Kohei Shitara, Chief of the Department of Gastrointestinal Oncology at the National Cancer Center Hospital East in Kashiwa, Japan. Welcome. Welcome. Ohio. And Professor Eric Van Cutsem, a professor at the University of Leuven and head of digestive oncology at the University of Hospitals in Leuven, Belgium. Welcome.
Thank you.
Professor. Thank you so much for joining us. Let's begin. So friends, we're going to start off with some basics, talking a little bit about global trends in gastroesophageal cancers. I'm so happy we have this group here today to represent the US, the EU, and Japan in terms of looking at treating gastroesophageal cancers. So there's a lot of discussion about different epidemiologies of gastroesophageal cancers in different parts of the world. So Peter, tell us a little bit about the thoughts behind East versus West in gastroesophageal cancers.
Sure. So I think one of the interesting aspects of gastric cancer in the United States is that it's a success story, right? So basically back in the 1920s, 1930s, this was probably the leading cause of cancer death in the United States. And with the implementation of refrigeration, improvements in health, sterilization of foods, preservatives, the incidence of gastric cancer has come down dramatically in the United States, so that it's no longer a top 10 cancer. Now that's really a phenomenal success, and in many ways in the United States, we sort of now are changing our minds about preservatives and trying to eat a more natural diet. But it's interesting what that's going to do with our incidence of gastric cancer. So in comparison, I think in the world, esophagogastric cancer is the second leading cause of cancer death. And that's primarily due to the high incidence in East Asia, where it really is a significant problem and remains a significant problem. In Europe, I think it's still, the sixth leading cause of cancer death. So I think it's very interesting how different parts of the world have varying incidences, and I think it really has to do in many ways with the diet that is eaten, and to a lesser extent with H. pylori, although I think there the incidence is relatively similar across the continents. But it is a phenomenon that is remarkable.
So Yelena, New York City, headquarters of the Power Lunch, right? So we were concerned a while ago about an increasing incidence in what they were calling the rich white man's disease, sort of an association of different risk factors with the lower esophageal cancers. Can you tell us sort of what the thought was behind that, particularly in the Western countries?
Sure. Well, first of all, New Yorkers don't eat lunch. We're too busy. Go. And I think some of it is environmental. And to Peter's point, distal gastric cancer is on the decline worldwide. But alarmingly, GE junction, gastroesophageal junction adenocarcinomas are on the rise, particularly in folks without significant any family history or risk factors. reflux and some of the obesity and environmental factors may play a role. But in my clinic, there's an epidemic of people in their 40s, 50s who exercise and do everything right and still develop this serious problem. And a lot of it, what I tell my patients, is that it's a combination of the environmental exposures, but also the patient's vulnerabilities and the germline predispositions to these tumors, and that's an important area to explore.
Yes, we're definitely going to touch on that a little bit later. Dr. Shitara, in Japan, you screen for gastric cancers. Tell us a little bit about the thoughts about epidemiology there.
Yes, the incidence of gastric cancer is slightly decreasing recently, even in Japan, but still 150,000 patients are diagnosed as gastric cancer, even recently, and approximately 50,000 patients die from gastric cancer, even now. So screening is very important to detect early disease, which is cured by local therapy, but still many patients diagnosed as advanced disease. So one important epidemiological factor in Japan is actually Helicobacter pylori infection, very common in older age. But incidence is also decreased in younger age. So that might be the one reason of decreased incidence of gastric cancer in Japan. Another important factor is maybe salt-included food, salty food in Japan is a traditional food, which may be one of the cause of high incidence of gastric cancer in Japan.
And I actually lied, Yelena. Let's talk about the genetics.
Yeah.
So what are the high risk groups? What do you test for when you see somebody with?
Sure. So the historical perspective on hereditary predisposition syndromes with gastric cancer are the rare, very rare subsets. So hereditary diffuse gastric cancer, which is a very strict criteria of who qualifies for testing. Generally, it's patients with strong family history or patients who are younger than 35. And it's been described with the signet ring cell subtype specifically. And for those patients, we recommend for their loved ones to be screened, for their families, and in carriers of the gene, because there's such high penetrance of CDH1. In CDH1 germline mutant patients, prophylactic gastrectomies are recommended. That subset does not have a therapeutic implication yet. Other germline syndromes, such as Lynch syndrome or hypermutated MSI syndrome, is a very important syndrome therapeutically. And actually, data that's being presented at this Congress from our group and Sophia Stadler shows that hypermutated or MSI tumors specifically, 16% of them may have Lynch predisposition syndromes, or germline Lynch, without any other significant family history. So now, as you know, these panels of next generation sequencing are identifying these patients, it's important to test them on the germline. Beyond that, beyond FAP and some of the Peutz-Jeghers and other rare syndromes, the gastric and esophageal genetic predisposition syndromes just haven't been well described. And so there's a lot of effort now, as we're getting these PAN and GS panels, to also look at germline data, to look at whole exome analysis. Particularly at our institution, we're very interested in young population to understand, to answer this question, this existential question, why me? Why did I get this cancer?
So Kohei, in Japan, do you see a lot of hereditary gastric cancer as well?
So actually, no.
Yeah.
Very few patients, but still some patients have the Lynch syndrome with gastric cancer and the CDH1 loss and the BRCA mutation. We have some patients, but incidence is less than 5% among the all gastric cancer patients.
Yes,
but
I
this
think
is
the
very
Ashkenazi
important.
Jewish population was important. Thank you for bringing that up, BRCA alterations.
Yeah.